Thank you for joining Cancer Support Community Atlanta for Treat the Cancer and Protect the Heart, moderated by Dr. Cheryl Jones with Georgia Cancer Specialists and facilitated by Dr. Jack Chen with Northside Heart. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website, cscatlanta.org, to see a complete list of live and recorded programs. Click the Join Us tab and complete a new attendee form to stay connected to all future programs. Welcome everyone to today's program, Treat the Cancer, Protect the Heart, featuring Dr. Chen and Dr. Jones. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website, cscatlanta.org, where you can see a complete list of the virtual oncology programs offered. These range from support groups to stress reduction programs like Tai Chi and yoga to monthly nutrition seminars. Next week's nutrition seminar, featuring Kristen Kukolowski with Northside Hospital Cancer Institute, will be focusing on heart health. To register for that program or any other of our virtual programs, we invite you to visit our website, cscatlanta.org. As a reminder, everyone will remain on mute. Throughout the presentation, we invite you to enter questions into the program chat box, which Dr. Chen and Dr. Jones will address at the end of the program, time permitting. I'm excited to welcome today's moderator. Dr. Cheryl Jones is board certified in internal medicine and medical oncology. She completed her residency and fellowship at the Medical College of Virginia in Richmond, Virginia. Dr. Jones currently serves as the Vice President for Georgia Cancer Specialists, where she practices at the Macon location. Dr. Jones is active in local and state medical organizations and has served as president of Bibb County Medical Society, the chief of staff for Coliseum Medical Center, the American College of Surgeons Cancer Liaison Physician, as well as serving on the board of directors for Medical Association of Georgia, the Middle Georgia Education Foundation, the Georgia Physicians for Accountable Care, the Middle Georgia affiliate of the Susan G. Komen Foundation, the American Cancer Society in Daugherty and Bibb counties, and the state of Georgia. So with that, welcome Dr. Jones, and I will pass it off to you to begin today's presentation.
Well, thank you, Katie. You know, February is Heart Health Awareness, and we know that 1 in 3 Americans have heart disease. But in cancer patients, more than half of the cancer patients have at least one risk factor for heart disease, such as hypertension, hyperlipidemia or high cholesterol, obesity, diabetes. And from the cancer treatments, whether chemotherapy, medications such as hormone therapies and some of the new oral agents that we have, and radiotherapy, we further increase their risk of developing heart disease. So we are so honored that Dr. Chen is going to help us today treat the cancer and protect the heart. Now, Dr. Chen is board certified in cardiovascular and interventional cardiology. He completed his internship, residency, and fellowship in cardiovascular disease at Cornell University in New York City and the Memorial Sloan Kettering Cancer Center in New York City. He's currently a director for interventional cardiology at Northside Heart and Vascular Institute at Northside Hospital. And Dr. Chen is the medical director for the Cardio-Oncology program at Northside Hospital, and he's often recognized as a top doctor by all of the peers in the community. So Dr. Chen, tell us how we can treat the cancer and protect the heart.
Well, thank you very much, Dr. Jones, and thank you so much for inviting me. Just as an aside, I just heard that you're from the Medical College of Virginia, now called Virginia Commonwealth University. I actually grew up in Richmond, and I did not know that. And so we have something in common. But back to the actual talk. Thank you, everyone, for joining us. And you know, what is the rationale for worrying about the heart in cancer patients? As we know, cancer is defined by abnormal cell growth or proliferation. And these are abnormal cells that just grow without any control. And the treatment, of course, from Dr. Jones and her colleagues is to destroy these abnormal cells. The heart, unfortunately, a lot of times shares similar receptors or recognizable markers as the cancer cells. And also, unlike other organs, heart muscles, unfortunately, cannot regenerate once they are destroyed. These are called cardiomyocytes. Cardio meaning heart, myo meaning muscle, and cytes meaning cells. So in effect, heart muscle cells sometimes are innocent bystanders of cancer treatments. One of the kind of the prototypical, most common example we use are women with breast cancer. And a lot of times these are young, otherwise fairly healthy women. Two very, very effective and life-saving medication, chemotherapy agents are Herceptin and Adriamycin. But unfortunately, these two are also, unfortunately, somewhat toxic to the heart. And as an example, a young woman who actually goes into complete remission after treatment with these agents, believe it or not, has a higher chance of dying from heart disease subsequently than from recurrent breast cancer. So why do we worry so much about it now, more so than we did before? The long-term cardiac effects of the cancer treatments really have only been apparent in the recent several years, because quite honestly, in the past, cancer patients died before they developed a lot of these long-term sequelae. So we didn't see the effects on the heart because the patients succumbed to their cancers before we even saw it. And so the bottom line is the cancer doctors are just doing too good of a job, and now these patients are surviving to see the effects on their heart. So as you can see on the top are the anti-cancer drugs of multiple types, immunologic and others. And these are compounds under FDA review. Now this slide is a little dated, but the pattern is fairly similar. So the bottom line is that new cancer drugs are just coming down the line every single day with new hope for cancer patients, and more so than really most other forms of medications for other conditions. And that's another reason why these patients are now doing so well from an oncologic standpoint, and again, living long enough for us to see the potential cardiac effects. So here is a plot of cancer deaths in the United States. And as you can see, it's concentrated down here, and unfortunately, Georgia is somewhere in there. And lo and behold, it's almost an identical map of heart disease distribution in this country. In this graph, we look at the presence of CVD, which is cardiovascular disease, in patients with cancer. And these include patients with coronary artery disease or heart artery blockages, carotid artery disease, neck artery blockages, peripheral vascular disease, blockages in other vessels, stroke, heart failure, or really anything else. And as you can see, with multiple types of cancer, anywhere from 20 to 40% of cancer patients will have coexisting other heart problems or cardiovascular problems. So in 2010, is estimated at 1.5 million new cases of cancer. And in 2014, that's gone up to 1.650, and it continues to go up pretty much every day. And most of these patients are going to need chemotherapy for their treatment. Not surprisingly, when you look at the plot over time, the incidence of cancer continues to go up. And this is the age distribution. But the treatments now are so good that most of these patients actually are going to do fairly well. So here's an interesting slide where we look at the 5-year survival rate. So the higher the bar, the better your survival of patients with different types of cancer: lymphoma, breast cancer, colorectal, lung. And here we have patients with heart failure and heart attack. So unfortunately, it looks like for a lot of these patients, it's better to have cancer than to have heart disease. But what you don't want to have is both, right? Because these are patients who have both heart failure. This is heart failure induced by doxorubicin, which is Adriamycin, one of the breast cancer agents, which is also used for many others. This is also in patients with heart attacks. So clearly, the combination of having cancer as well as heart disease is a very, very dangerous one. So if we look at the patients, again, here's survival on the y-axis, and this is a time on the x-axis, number of years. The green bar, as you can see, is patients with lymphoma, let's say, who received chemotherapy, and this is their survival. The yellow is these patients who have doxorubicin, or one of the chemotherapy agent-induced heart failure. So unfortunately, when you develop chemotherapy-induced heart failure, your survival is much worse than it would be from just the cancer alone. And it kind of makes sense. This top graph, again, we're looking at survival on the x-axis, excuse me, the y-axis, in years on the x-axis. And these are, again, patients with diffuse large cell lymphoma after a chemotherapy regimen. And what we see is that even though, of course, initially the survival does drop, it tends to plateau off at around 5 years. And so, at least according to this particular series, once you get past 5 years, you're doing pretty well. It's going to stabilize. Unfortunately, those patients that develop chemotherapy-induced HF, which is heart failure, have a probably more exponential drop at the end of 5 years, to where it almost comes down to zero. So this is a very sad statement that you could be potentially go into remission and maybe even be cured of your lymphoma. But if you happen to have a cardiac effect from your chemotherapeutic agent, then your survival becomes much worse. So it's really what we call a crossroads subspecialty, where cardiologists deal with patients who have had chemotherapy and radiation therapy treatments for their cancer and their particular needs. Now, we are probably all aware of at least some of what we call coronary risk factors, and a lot of these kind of make sense. People who are older are going to be at higher risk for heart disease, people with a family history, and unfortunately, men will have a higher risk because estrogen is potentially protective. So once a woman has gone through menopause, then her risk of heart disease starts to catch up to the man. Premenopausal women have about a 10-year advantage over their male counterparts. And the other things that we hear about a lot, high blood pressure, cholesterol, diabetes, obviously, we're all aware of these, tobacco, obesity, sedentary lifestyle, or a low HDL. HDL is what we call the good cholesterol. So if you have a high good cholesterol count, that's actually potentially protective. And we think that this can be raised with exercise. Now, what you'll notice here is that there are three things you really can't change. You can't change your age, you can't change your family, and for the most part, without making a socially incorrect statement, you cannot change your gender, at least in most vast majority of cases. But you can change your tobacco, you can change your weight, you can take medications to control your blood pressure, limit the salt, take medications to control your lipids or cholesterol, and watch the diet, and exercise more. So these, although these are general, what we call coronary risk factors, they're also basically the same ones that we look at in patients who undergo chemotherapy. And here is kind of a list of things that we kind of check off when we see patients about to receive chemotherapy. Obviously, very importantly, are the actual chemotherapeutic agents. And there is no way I could make an exhaustive list of all the chemotherapeutic agents because more are developed every day. But these are just very few examples. Some of the more high-risk ones include Herceptin or trastuzumab, which we mentioned, mainly used for breast cancer. Doxorubicin or adriamycin is in a group called anthracyclines, which again are often used in breast cancer, but also many other types of cancers. Cyclophosphamide, ifosfamide. And these are the examples of very, very high-risk chemotherapeutic agents. Another group, sunitinib, sorafenib, these are also a group that have some potential cardiac effects, not quite as toxic as we believe the other ones are. And some of the other ones down here, lapatinib, dasatinib, these bevacizumab, these are all kind of lower risk, but still potentially can have cardiac risk factors. Excuse me, cardiac effects. These are basically the risk factors that we talked about, some of them. But also people have coexistent heart disease, people with heart failure or cardiomyopathy, people with a known history of heart artery blockages or coronary artery disease, high blood pressure, diabetes, as we discussed. Certainly patients who've had a prior, who've had a prior treatment with anthracycline or one of the other high-risk medications. Many times we keep a count of how much they've actually received over their lifetime. History of chest radiation. Now, the very young and the very old tend to do worse. And if you think about it, it kind of makes sense. The very young, their body, not just their heart, but just in general, their body tissues are rapidly developing and growing. So any treatment aimed at abnormal growing tissue, which is cancer, potentially could attack more cells in rapidly growing younger people. And people who are older just generally tend to have many more medical issues and not in such great health. So compounding that with potential cardiotoxicity makes it worse. Women, unfortunately, tend to do a little bit worse when you have chemotherapy-induced heart problems. And it's not entirely clear why that's the case. It may have to do simply with the fact that they have a smaller body mass in most cases. They're smaller physically, and the effects tend to be a little more magnified. There are potential treatments, which we can talk about a little bit. These are fairly standard heart medicines that we use for other conditions as well. So chemotherapy, we all know what that means, induced cardiomyopathy. Cardio, again, means heart. Myo means muscle. Pathy means disease. So cardiomyopathy meaning a disease of the heart muscle, and in most cases that implies that you have what we call heart failure or weakening of the heart muscle. So just a little bit of terminology here. A number you'll probably hear cardiologists and maybe even oncologists talk about is called an ejection fraction or an EF. And that is a measure of the strength of the heart muscle. And here's the formula for the derivation, which is the volume at peak relaxation or diastole when the heart relaxes, minus the volume at peak contraction or when the heart contracts or squeezes, divided by the volume at peak relaxation or diastole. And in plain English, what that really means is if you look at the heart muscle, it's squeezing blood out. With each cycle that the heart squeezes, the amount of blood that's squeezed out by the heart divided by the amount of blood that was there before it started squeezing, the ratio of that is called the ejection fraction. So a normal ejection fraction is over 55%. So it's not 100%. People hear 55% or 60% and they start getting a little concerned, but that is normal. Normal is not 100%. Nobody has 100% ejection fraction. So again, it's the amount, it's really the fraction of blood in the heart that gets squeezed out is a simpler way of looking at it. There is a new measurement, which we are paying a lot more attention to now, called global longitudinal strain, GLS, or most people just call it strain. I won't spend any time on this. There's been a lot of research on it. But suffice it to say, if you hear this term, basically, it's kind of like a pre-ejection fraction. So we believe that if you have a decrease in the global longitudinal strain, that may be a precursor of a drop in ejection fraction before we actually see the latter occur. So I'm going to teach everybody here to read some heart tests, cardiology tests today. There will be a quiz afterwards. So if you look at the top row, excuse me. If you look at the top row here, this is the normal patient, the 2 on the top, and the abnormal patient, the 2 on the bottom. So the left frame is an echo. These are echocardiograms, ultrasound of the heart. And the left frame, as you'll see outlined by the red, this is the left ventricle or the pumping chamber of the heart. And this is how much blood is in here. This is the empty part. This is the volume of the left ventricle when it's fully relaxed. And then when it squeezes, you can see how it's very well contracted. Probably over half of the volume has been ejected out into the body. So the heart muscle chamber here is very small, and that's normal. Compare that with someone who has cardiomyopathy or weak heart muscle, and what you'll see is that here in diastole, when it's relaxed, it is big. When it contracts, it pretty much looks the same. So there's very little contractility, and this is someone with an ejection fraction I would estimate of about maybe 10%. Or maybe even less, and really is in a lot of trouble. Now, there are many different types of cardiomyopathy, many different causes, blocked arteries. Another kind of unique and poorly understood one is called peripartum cardiomyopathy, right up here. And this occurs in women right after they deliver. Peri means around, partum means delivery. So unfortunately, some, not many, otherwise healthy women, young women, after they deliver, will develop a cardiomyopathy, will have weakened heart muscle. And we don't really understand why that happens. There are other types of idiopathic, meaning we don't really know what caused the heart failure. People with blockages or ischemic heart disease, patients with HIV, cardiomyopathy tend to do pretty poorly. But you'll see in here doxorubicin, the yellow line, which is again adriamycin, our prototype chemotherapeutic induced cardiomyopathy. These patients really do not do very well if you develop it, with a poorer prognosis than someone with, let's say, peripartum or even people who have weak heart muscle because of blockages and heart attacks. Very busy slide that I'm not going to spend much time on, but suffice it to say, this is the National Comprehensive Cancer Network, NCCN, and it pretty much just kind of says what we talked about before, which is the initial assessment of patients who are about to receive anthracycline or the doxorubicin adriamycin therapy that we talked about. And most of this really is kind of common sense type things. Any history of heart failure or other heart problems, if they look like they have a lot of fluid overload is a sign of heart failure. The traditional risk factors that we talked about, high blood pressure, diabetes, cholesterol, family history, advanced age, history of other heart problems, personal habits, smoking, alcohol, and certainly their oncologic history is very, very important. And based upon how many of these boxes get checked off, what the risk of the patient is, then we may want to consider doing some testing and determines how often and how long we will follow these patients from a cardiac standpoint. So not all the chemotherapy agents that affect the heart cause heart failure per se. That tends to be the main one, the one we focus on, but there are other potential side effects too. This group of agents known as tyrosine kinase inhibitors, or TKIs, can sometimes cause a pericardial effusion or some fluid around the heart, can cause high blood pressure, or even heart attacks or blood clotting inside the vessels. Another group known as antimetabolites, 5-FU is a fairly common one, can cause coronary ischemia or blockage in the coronary arteries, or even coronary vasospasm, where you don't actually have a physical blockage, but the walls of the artery spasm and squeeze, so effectively you're still not getting enough blood flow, and it functions as if it's a blockage. But the good thing about spasm is that a lot of times it will relax once the inciting agent is taken away. Another very exciting group of treatments is known as immunotherapy. And I certainly, by no means an expert on these, Dr. Jones and her colleagues can tell you much more about these than I can. But these are incredibly exciting because what these agents do is they boost the body's own immune system to recognize and to fight these cancer cells a lot better than it's doing. So you're using the body's own defense system to fight the cancer cells. But unfortunately, as with some of the chemotherapy agents, heart muscle cells are at times mistaken by these immune cells once they're triggered. And so they end up attacking the heart muscle as well. These are some groups of immunotherapy agents that you may have heard of, CPIs, checkpoint inhibitors, T-cell transfer therapy, monoclonal antibodies. Coincidentally, the two available vaccines right now for COVID are mRNA vaccines, although they certainly function differently than immunotherapy. The idea is the same. These vaccines also trigger the body's own immune system to recognize and fight the virus in an analogous type of strategy. So when do you want to intervene and treat these patients if they have a heart problem? Well, what we find is that the earlier the better, which kind of makes sense. The question is, how do you catch it before it becomes very readily apparent? Well, one thing you can do is you can look at the patient's risk factor profile, both demographically, that is, whether they're a smoker, whether they're older or have diabetes, as well as the agents that are being used, and also the oncologic history if the patient's had cardiotoxic chemotherapy agents or radiation, chest radiation in the past, then clearly that puts them at much higher risk. You know, I analogize this to kind of like trying to time the stock market, right? So we all want to buy low and sell high, but you never know when that price is going to go up. You never know when it's going to go down. You try to predict it based upon past performance, but you know, most people are a lot smarter than me, can't even do that, and I certainly can't. So a lot of the challenge here is to figure out when to intervene, if intervening at all, because obviously, even though a lot of these cardiac medications are fairly benign, no medication is without side effects. So what are the potential treatments for the heart in these patients? And it really is pretty much a lot of the same medications we now use for heart disease of other reasons. And again, we want to try and institute it early because the data seems to show that that's more helpful. For the most part, the way these medications work is they just decrease the stress on the heart muscle, right? Which kind of makes sense because if you have a weakened heart muscle, you want to decrease the work that it does. And again, I liken it to, let's say you go lift weights in a gym. If you are healthy and young and your muscles are strong, the more weights you lift, the stronger your muscles are going to be. However, if your muscles have been injured, if they are strained, you don't want to go and bench press as much as you can because that will actually further hurt the muscle. You want to decrease the stress on the muscle and hopefully allow it to recuperate. Beta blockers are a group of medications that you may have heard of, and they're very, very common. Their two effects are to decrease the heart rate and the blood pressure, and of course, decrease the stress in the heart. Some examples of the ones we use are carvedilol, metoprolol, succinate, and bisoprolol. These are all beta blockers we use in patients with heart failure, whether or not they're chemotherapy induced. ACE inhibitors, you may have heard of, or ARBs, angiotensin receptor blockers. These decrease the blood pressure. They don't have any effect on the heart rate. And they're also very useful in patients with heart failure for any reason. Some of these are lisinopril, enalapril, captopril, benazepril, losartan, valsartan, olmesartan. And you'll start to see a pattern in the names of these medications, right? The suffixes, the last 3 or 4 letters, tend to be the same for every particular class. We keep track of these patients serially, obviously with examinations and talking to them, but also objective measurements of the ejection fraction or the strength of the heart. And these are done by cardiograms, which are ultrasound tests of the heart. And there are different schedules as to how often these need to be done. It really depends on your risk and what agent you're receiving. And of course, we individualize these. It's not a one-size-fits-all. For people with very high risk profile, we may want to do it during therapy, every other cycle, after therapy, and then even up to 1 year post-therapy, and maybe even longer, because some of these can have fairly long-term side effects, even way beyond the actual treatment. In patients who have a fairly high risk score by the parameters that we talked about, we may actually start to initiate some of these medications, the ACE inhibitors, ARBs, or beta blockers, before they actually demonstrate any heart function, to hopefully prevent or at least delay the onset of cardiac sequelae. So we talked a lot about chemotherapy. I'm going to just spend a little bit of time about radiation. Radiation obviously is doing the same thing that chemotherapy is, which is to destroy the abnormal cancer cells. However, if you have chest radiation, especially left-sided chest radiation, because the heart is on the left, that can cause direct injury to the heart muscles and valves. So one of the things that we always check for in patients who receive a fair amount of left-sided chest radiation are valve problems. Valves are basically doors that are within the heart chambers. We have 4 of them. There are 4 chambers in the heart. There's a door basically in between each one. And these are one-way valves, one-way doors that only open in one direction, then they close to prevent backflow of blood, so the blood can only flow forward. So 2 things can happen to valves. They can not open enough, or they may not close enough. In either event, it's bad for the circulation, it's bad for the blood flow, and patients can have a lot of problems. And if they are severely damaged, they may require repair or maybe even replacement. So here is a fairly old graph looking at radiation-induced heart problems and severe aortic insufficiency, which is the aortic valve, one of the main heart valves. It doesn't close properly. We call that insufficiency or regurgitation. And 60% had developed either mild or severe aortic regurgitation more than 20 years after their treatment. In 9% of it, and there is a 9-time risk, 9-fold risk of having to have valve surgery at 15 years after treatment. Now, again, this is a fairly old slide from 2003. So the recent advances in shielding to protect the heart during radiation therapy have really dramatically reduced these numbers. But I just wanted to show this as a kind of reminder that these are potentially also very cardiotoxic treatments. Not only can the valves be affected, but also the coronary arteries. So the coronary arteries are these 3 very small arteries. They're on the average about 2 to 4 millimeter diameter that are on the surface of the heart muscle, and they bring blood to the heart muscle. So if you have a blockage in one of these arteries, that's what causes a heart attack. And if you have multiple heart attacks, that can lead to weak heart muscle. So the radiation can directly injure the heart artery walls and actually lead to blockages like this, making the artery much more susceptible to cholesterol deposits because it's been injured. We talked about breast cancer in specific with chemotherapy, but it's also important to talk about that in radiation therapy because obviously breast cancer patients who receive radiation receive it in their chest, especially women with left-sided breast cancer radiation treatments. So we have a lot of patients who are treated with this, and there's a tremendous number, over 2 million, that are at risk. And what we see is that the risk of having a coronary event, that is having a blocked artery such as a heart attack, dramatically goes up when you have radiation treatment. But not only that, each one of these curves is an additional coronary risk factor. So it just makes sense if you have radiation therapy and you also have other risk factors for heart disease, clearly your risk goes up the more risk factors you have after radiation therapy. So I'm going to talk very briefly about some of the tests that we do, and you'll hear these terms probably, and this way you'll have at least some idea what we're talking about. Stress tests obviously is something we do to kind of stress the heart a little bit and see how it performs after doing exercise. Most of the time we'll do nuclear stress tests, and that involves injection of a little bit of radiation, which then we look at the blood flow under a radiation camera. Some of the terms you'll hear are nuclear stress tests, thallium or sestamibi. Thallium is an older agent that we really don't use anymore. Sestamibi is the new one, or MIBI. But most of the time we'll just call these nuclear stress tests. So here you see a patient walking on the treadmill. He would have had an image of his heart before and after his exercise, and we compare the before and after pictures. Along with that, we always do a continuous electrocardiogram, or ECG, and I'm going to actually teach everybody how to read an EKG and read a stress test. It's actually not that hard. Cardiologists are not very complicated people. Most of the things we do are actually fairly simple. If you look at the EKGs, what you'll notice is that there is a spike. This is time axis, so this is over time, that each one of these spikes basically is a heartbeat. Okay, the spikes look different because they're taken at different parts of the heart, but each spike represents a heartbeat. And what you'll see is that after each spike, there's what we call an ST segment. And this ST segment is horizontal, and it's pretty much on the same level as the rest of the horizontal lines, right? All of this is on basically a single level. When you have what's called ischemia, or where the heart is not receiving enough blood flow, then this ST segment drops down. It's called ST depression. You don't want to see that. So see what happens when the patient exercises. Clearly, the spikes become more frequent. The heart rate goes up. That's totally normal. But what you'll see in all of these red arrows is that the ST segment, hopefully this is visible on the slide, but you'll see the ST segment, the horizontal area right after that spike, is much lower than it was to begin with, right? That's what we call ST depression. And a couple of these leads, the ST actually is higher, ST elevation. That's actually worse than ST depression. So this patient really has significant coronary blockages just based on this test. When we add the nuclear part to this, we look at the blood flow, and what you'll notice is that there are 6 rows here. The top row, actually, I apologize, these are reversed. The top row is the exercise, the bottom row is the rest. So the red part, or the pink part, is where the blood flow is. And if you compare the first of each of these 2 rows to the second of each of these 2 rows, you'll see that here there's a part missing and a part missing here that fill back in during rest. Again, I apologize. These 2 labels are reversed. The exercise should be on top and the rest should be on the bottom. And what we call this is reversible ischemia. In other words, during exercise, part of the blood flow to this part and this part of the heart is not working. It's not sufficient. When you're resting, it's okay, because if you have a blockage that's not totally blocked, during rest, you don't require that much blood flow, and it's enough to supply the heart muscle. When you start exercising, you require a lot more blood flow. You're making much more demand on your heart, and the minimal amount of blood flow from a reduced artery flow due to a blockage, while it may have been sufficient at rest, is no longer sufficient when you have a higher demand on your heart. And you'll see these are just different cuts of the heart, different ways to look at it. And clearly, if you compare the top row to the bottom row, there's a significant difference. This entire area is blued out, whereas it comes back to normal here. Same here, you'll see the tip or the apex is dark, and it fills back in during during rest. This patient, like the EKG portion of the test, in this part of the test, we confirm that clearly he has significant coronary blockages. So then what do? Well, we do what's called the cardiac catheterization, where you may have heard this. It's called an angiogram. We take a catheter or a thin tube, and it goes in through either your wrist or your groin, put it up into the heart, and we inject some X-ray dye and look for blockages. This is my catheter, and normally this is the right coronary artery, and it should come down in like a letter C. But what you'll see is that it stops right here. There's nothing beyond the tip of this catheter. So this entire right coronary artery is gone. That supplies the inferior or the bottom of the heart muscle, and that whole area is having a heart attack. After we establish flow, we put in a stent, which is a spring that stays in the artery. Kind of looks like the spring in your ballpoint pen, a little more expensive. And then establishes flow, and you've got a really nice brisk flow down the entire vessel. And like I said, it kind of looks like the letter C. So this patient was having a heart attack, which we then interrupted by reestablishing the flow that was absent before. You know, the entire cardio-oncology discipline is a multidisciplinary approach. Of all the doctors, the most important ones, of course, the doctors that treat the cancer, the radiation therapists, the medical oncologists who use chemotherapy, and the surgeons who operate on the patients. We believe this to be an entire team, of which the cardiologist is a component. And obviously, the patient is at the center of this and should always be the one to make the final decisions with educated recommendations from the different doctors. Equally important, and maybe even more important, are a lot of the staff, you know, the nurse practitioners, the physician assistants, nurses, the secretaries, the assistants, who are able to deliver much more hands-on care sometimes than the doctors can, and they're the ones that a lot of times reach out to the patients because they have more time to do so. And I really encourage everyone to really stay in touch with their entire team. The adage of it takes a village is really very appropriate in this instance. This is a map of the cardio-oncology centers in 2011, and there were several of them. And this was actually one of the ones that I trained at during my cardiology fellowship, was Memorial Sloan Kettering in New York. 5 years later, we have a few more, and a few more in Atlanta. And the following year, we established it at Northside in 2017. Our program is, I believe, very robust and continues to grow. But we always welcome more, more support, more questions, anything we can do to help our patients and our oncologists. That's what we're here for. And I appreciate your time. I kind of ran a little bit over, and I hope that that we were all able to learn a little something today. Thank you.
Well, thank you, Dr. Chen. That was very informative. We have a few minutes to answer some questions, or do you need to rush off?
Yeah, I probably need to go, but I can probably take a couple of questions. I'm running kind of behind today. I apologize.
Right. Well, so let's start with one question. The patient who's had breast cancer approximately 4 years ago is doing well now. Cancer, has high blood pressure and high cholesterol that their medical doctor, their internist, is managing. Does this patient need to see a cardio-oncologist for a consult, or continue with just their internal medicine physician?
Yeah, that's a great question, and I don't know that I can give you an absolute answer to that. I think if you were to ask, different cardio-oncologists, they might give you different answers. This patient certainly does have a couple of risk factors: the high blood pressure and the, I believe, high cholesterol. I don't know her age, and I won't ask it, but she's not a man, and I'm assuming she's not a smoker. I don't know the weight, and I, of course, will not ask that. I think that if she is doing well and she has had no evidence of any cardiac effects from her treatment, and she's 4 years out, it's probably not unreasonable just to kind of for the internist to keep an eye on her. But at the very first sign of any issue, I think I would have a low threshold to have a consultation. You know, the other question would be, should she have an echo 4 years out? And again, I don't know the answer to that. I'm assuming she probably got adriamycin. Herceptin tends to be more of an acute cardiomyopathy, usually during treatment or shortly thereafter. Adriamycin can have long-term effects, so maybe at some point get a follow-up echo. May not be a bad idea if that looks good with good strain. Then this patient may not need a cardio-oncology evaluation. But I think I would have a fairly low threshold to do so if anything changes.
Okay, all right. And if you've had heart disease and you have cancer, since they're both so common in the United States, can you always tell if they're related to one another? Kind of a chicken and the egg question.
I guess it depends on chronologically. You know, obviously, if you have had a heart attack before you had any chemotherapy and you had heart failure, clearly that's not related to the chemotherapy. But conversely, if you develop heart failure after you've had chemotherapy, especially if you've had one of the cardiotoxic agents, then that certainly could be. And like you said, you know, like the question stated, the demographics of people with heart disease and cancer tend to be kind of similar. You know, it tends to happen more in older folks. And unfortunately, heart disease is just so prevalent these days that everybody knows somebody who has heart problems. And they may be related, they may not be, but regardless, when you have both, clearly your prognosis is compromised.
Thank you. And there's one other question that I actually know the answer to. It says that after treatment for cardiac issues, is there in any period where you're at a safe time zone? This is somebody who's several years after their treatment and they've not had any heart issues. And because the cardiac issues from cancer therapies can occur 10 and 20 years later, I don't think there is any safe period. We have to work on all of our modified risk factors and follow up with their physicians. Do you have any other comments on that, Dr. Chen?
Oh, absolutely, absolutely. And that's why these survivorship programs from the oncologists are so important, not only to monitor their oncologic status, of course, but also their heart status. Now, it may not necessarily be crucial for them to see a cardiologist on an ongoing basis if they didn't have any cardiac involvement during treatment or after, but obviously they should have follow-up with their oncologist, who, if they detect any cardiac changes, then they will notify the cardiologist.
So thank you. So that's a great segue to send it back to you, Katie, that, you know, the survivorship programs for years following treatments for all types of cancers and the issues that develop for patients is a high area of research and interest in the cancer support community. And I actually look forward to hearing the nutrition talk on cardiovascular risk next week. So thank you all for joining us.
Thank you, everyone. Thank you, Dr. Jones. Thank you, Katie. Bye.
Thank you both. Thank you, Dr. Chen, for such a great presentation, and thank you, Dr. Jones. Yes, if anyone is interested in our program next week on nutrition and heart health, please visit us at cscatlanta.org, where you can register for that program. And I guess, Dr. Jones, let's see. I think that was most of our questions. Did you have any other ones that came in that you were wanting to address, or?
I was going to say there was one that came in and asked that.
Thank you so much for doing this.
That she has been diagnosed with chronic lymphocytic leukemia, so different from some of her solid tumor cases, and is on watchful waiting. So has not yet received any treatment for the cancer. Chronic lymphocytic leukemia is very common, just like heart disease, and so the atrial fibrillation is probably in no way related to the CLL. However, there may be a time in her life where she will need treatment for the CLL, and because some of the medications and the atrial fibrillation medications have some overlap and some side effects that have to work together, her cardiologist and oncologist will be working very closely together. So in all of the rest of the questions is, when should you see a cardio-oncologist? I think working, as Dr. Chen said, with the team, your medical oncologist, your internist would decide if you're at increased risk or you need even a consult that can help provide a game plan for the primary care physician to follow up in the survivorship issue. But please remember, especially for women, I know this conference is men and women attending, but women often do not have the typical presentations for heart disease as men do. And so we need to be aware of that during the month of February.
Yes, absolutely. Thank you so much, Dr. Jones, for being so generous with your time and expertise. I do want to let everyone know a recording of this program will be added next week to our website. Again, that's cscatlanta.org, and you can find it under the video tab. And again, you can find a complete schedule of all of our programs on our website as well. So thank you guys for joining us, and we hope to see you soon. Take care. Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.